Hi, everyone. My name is Dr. Rahul Banerjee. I'm an assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle, Washington. And today I'll be talking briefly about the BENEFIT trial. Isatuximab, lenalidomide, dexamethasone, and bortezomib in transplant-ineligible multiple myeloma that was published earlier this year in Nature Medicine. I'll be talking about this as if it was one of my patients coming to me and have a copy of this paper in their hand that a friend or loved one forwarded to them. What do I tell them? So, thank you for asking about this study. I think it's a very interesting one. The BENEFIT trial was a study of 4 drugs versus 3 drugs in patients with multiple myeloma, newly diagnosed, starting treatment for whom autologous stem cell transplant or a bone marrow transplant is not planned, which for many of our patients are patients who are older in the US, for many of our patients over the age of 70 or 75, our default is possibly to consider transplant. We don't really push for it. What do we do for those patients? Historically, we've been giving patients 3 drugs. For example, a regimen like DARA-RD or ISA-RD. DARA-RD is daratumumab, which is Darzalex Faspro. R is lenalidomide or Revlimid, and Dex is dexamethasone or steroids. And that works quite well for patients. There was a study of that regimen called the Maya trial, where patients, even without getting a bone marrow transplant, they were in remission for 5 years on average with that regimen. And these, again, are patients who are older, a little bit less fit, patients who transplant honestly might have had real harms for them. So a lot of the patients are nervous about giving up on transplant. And I'm like, no, it's great. With DARA-RD, again, 5 years of benefit on average. The question is, can we build on that? So what the study did was rather elegant. Now, they did not use DARA, which is daratumumab or Darzalex Faspro. They used isatuximab or Sarclisa, which is now approved in the US for upfront usage. At the time, it wasn't. And it was, to be fair, it was a French study, not a US study. And so they gave patients the default. It was a randomized study. So patients newly diagnosed, not yet started treatment, were randomly assigned to either get ISA-RD or ISA-VRD. ISA-RD is Sarclisa, isatuximab, Revlimid, lenalidomide, and dexamethasone, which is very similar, I would argue, to DARA-RD, which is kind of our default. And this half of patients, the other half of patients got that, but also got bortezomib or Velcade. That's an injection once a month that we used to sometimes use for these patients quite a bit. And in patients who are getting transplant, we routinely use bortezomib or Velcade for those patients. And so what they found was actually that there was a benefit to adding a benefit to the benefit trial. There was a benefit to adding this once per week injection called Velcade or bortezomib to these patients. It's a benefit in terms of MRD negativity, which is a long discussion, but the reason it's relevant is actually MRD is, long story short, a measure, a very sensitive measure to cells hiding in the bone marrow. Even 1 in a million cells in the bone marrow, MRD can pick out. Being MRD negative doesn't equal cure, but it's certainly a good sign. And they found that the group that got the once weekly bortezomib Velcade added on did have much higher rates of MRD negativity, even within a month. Oh, sorry, even within a year, I'm sorry, of being diagnosed. If we're going to find out in a couple of years, does that correspond to patients being in remission for longer and feeling better, right? Because the whole point of care for multiple myeloma is to live longer and live better, and ideally to live longer in remission. We don't know yet. But the nice thing about this is because they looked at that endpoint of MRD negativity, they're able to tell pretty quickly. You don't need to wait 4 to 5 years to say that 4 drugs was better than 3 drugs. You found out pretty quickly. This is really, I think, a big deal for our field, again, because historically, for patients who were going to transplant, we would be giving them 4 drugs, like Dara-VRD, or in this case, Isa-VRD with the Velcade. And if they're not going to transplant, we'd give them 3 drugs, for example, Dara-RD, or less commonly VRD light, another kind of regimen. Here now, they show that even for patients for whom transplant is not planned, 4 drugs did seem to have a benefit. Again, if you were to ask, does giving 4 drugs, if I'm not going to transplant, make me live longer or live better? I don't know yet. Hopefully it will, because certainly the early science suggests that based on MRD negativity, based on not much disease in the bone marrow, but we'll find out. And so I think it's really changing the field here for patients like yourself, your hypothetical patient here, because if I think that you could get 4 drugs, if I think that you are someone who's eligible to get 4 drugs in terms of your side effects, because the Velcade, for example, does have a side effect of neuropathy, of nerve tingling in the fingers or pain in the fingers and toes. If I think that's a good drug for you, I'm not going to withhold it just because you're not planning to go to transplant. And so I think now, instead of me looking at patients like yourself and deciding everything based on are we going to do this transplant or not, is more, do I think you can get 4 drugs versus 3 drugs? If I think you can get 4 drugs with the Velcade, the bortezomib, let's do it. And then let's ask questions later down the line. We can decide about whether or not to do transplant or not. So I think it's a very big study in the field. For patients like you are coming to me right now, we're deciding whether to get 4 drugs versus 3. I would say talk with your doctor about it. In general, I think the study is changing the field that if you think that you could get 4 drugs and your doctor thinks that you could get 4 drugs, I'd rather start with that and ask questions later, because if it works well, transplant or no transplant. If it causes too many side effects, we can always go back down to 3. But I think now moving to 4 drugs as a starting point, a quadruplet, so to speak, is always helpful to think about with patients and discuss it from there.